Hello, everyone. Welcome back to the 2021 ASPCA Cornell Maddie's Shelter Medicine Conference. You are in the DVM track, and the sessions for the next 2 hours are going to be on canine and feline parvovirus. If that's not what you intended, you're in the wrong place. Then there are other stages that you can go to, so go take a look. It is a 2-hour track, but we're going to have a break in the middle, and we will be taking questions throughout. My name is Lena Datar. I'm from Cornell University's Maddie's Shelter Medicine program. If you have a question for the presenter or for me, please use the Q&A function under the Stage tab on the right of your screen. We will try to get to as many questions as we have time for. For any conference-related or technical questions, please use the chat function, also located under the Stage tab. This presentation qualifies for continuing education credit in jurisdictions that recognize race approval, as well as the New York State Education Department and the Association for Animal Welfare Advancement. Race and New York State verification certificates will be emailed a few weeks after the conference to the email address you provided during registration. All presentations are being recorded and will be available in a few weeks, and you will receive an email when the recordings are ready. Now, it is my absolute pleasure to introduce our speaker, Dr. Stephanie Janesco. Dr. Janesco completed her doctorate of veterinary medicine in 2004 and master's in epidemiology and shelter medicine residency in 2009, all at Cornell University. She is board certified in shelter medicine practice and canine feline practice through the American Board of Veterinary Practitioners and is also a certified animal welfare administrator. Stephanie was a member of the organizing committee for the shelter medicine specialty and currently serves as regent for the specialty. She is a board member of local and regional veterinary medical associations and a former board member and past president of the Association of Shelter Veterinarians. Stephanie is currently the vice president of shelter medicine services at the ASPCA, where she is responsible for leading and ensuring continuity across the organization's national shelter medicine network and within its direct care programs, as well as overseeing the Julie Morris Shelter Medicine Residency as program director. Please join me in welcoming Dr. Janesco.
Thanks, Lena, and thank you everyone for joining the conference, for hanging in. We're getting into the home stretch going into Sunday afternoon, and I'm really excited to have this opportunity to spend the next couple of hours speaking to all of you about what is a really important topic, and one that I know I have seen questions come up in different sessions across the conference related specifically to parvo or panleuk and what to do about it in dogs and cats. I did want to mention, as Lena said, this is our medical track. I did my best to aim this presentation to hopefully have a little bit of something for everybody. And so if this is not the track that you think you should be in, please don't hesitate to pop out. But if this is a topic that you're interested in, certainly don't feel like you can't stay if you're not a DVM, whether you're a veterinary technician, assistant, or any role in the shelter. Hopefully we'll have some good and helpful information for you here today. All right, so with that, I thought it would be helpful to start us off with a little bit of an outline for where we're going today. And as Lena mentioned, we're going to take a break in the session. We'll stick with the calendar in case you need to hop off, you were looking to join another session, or if folks are coming in. And depending on how far we get, how the questions are coming in with the sequencing of the slides, we'll sort of play it by ear in terms of where we'll take our break point, but we will keep you on time. And so overall, what we're going to cover today are some of those basic basic biologic facts about parvovirus that are really critical for understanding the disease. We'll talk about transmission, incubation, and shedding periods. We'll, of course, talk about clinical signs and diagnosis. And then we're going to spend a bit of time talking about treatment and a lot more time talking about prevention. I will warn you, vaccination is in the prevention section, and it is one of the last things that we're going to get to. So if you're wondering why it doesn't come up sooner, please hold tight and do know that we'll get to it. All right, so canine and feline parvoviruses are non-enveloped DNA viruses. And right there, that has two really helpful pieces of information for you. The first is non-enveloped or unenveloped, and that is going to relate to their resiliency in the environment and their susceptibility to regular cleaning and disinfection practices. And the other part that's helpful to know about this, is that they're a DNA virus. And DNA viruses generally are more stable and less mutable than RNA viruses. So something like influenza, for example, is kind of our classic RNA virus. And we think about all of the mutations and variations that we see. So one kind of helpful piece about parvoviruses, one sort of less helpful piece in terms of their persistence. We all know that they're highly contagious. They can be very easily spread, and they are environmentally resilient. So those things added up can make these a significant challenge to manage, whether we're talking about individual animals or certainly when we start talking about populations of animals. And we know that they can cause severe and potentially fatal illness in dogs and cats of any age. When we talk about parvovirus or panleukopenia in cats, what we're generally talking about is infection with a feline parvovirus. So the feline parvovirus or panleukopenia virus, that's a virus that's been around for a long time. It was first characterized almost 100 years ago, which is a little different than the more recent emergence of canine parvovirus. So most cats who get infected are going to get infected with the feline virus, but they can become infected with the canine parvovirus as well. And that may be infection that's asymptomatic, or it may be infection that causes them illness. Typically, when cats do get infected with canine parvovirus, we don't think of them as getting as sick as we typically see with the feline parvovirus, but that's not an absolute. And sometimes they do become seriously sick. There's been a handful of case reports of CPV2C infection in cats, for example, causing severe and sometimes really odd illnesses, things like intracranial abscesses or seizures. That's not the majority of the time, but it is something to keep in the back of your mind. When we talk about canine infections, we're just talking about canine parvovirus. So unlike panleuk, which has been around for a long time, parvo is still in the evolutionary world quite a new virus. It first emerged as a pathogen of dogs in the mid-70s. And since that time, there's been a few antigenic variants that have emerged. So pretty stable virus, but it has shifted a little bit. So we saw 2A in the very late 70s, 2B in the US in the mid-80s, and then more recently 2C in the early 2000s, starting in Italy, but spreading more widely. So the thought is that the canine parvovirus actually evolved from the feline parvovirus, although you'll occasionally hear thoughts that it might have been independent evolution. Regardless, we're still talking about the unenveloped DNA virus, and it's a pretty simple virus. It encodes, it's got a couple of open reading frames. Those encode some spike proteins, and the one that I'll just mention is called VP2. That is the one that's of most interest because it's been sort of best characterized. It's also the one that leads to those classifications for 2A, 2B, and 2C. Now, up until recently, with the exception of a couple of anecdotal reports, no one's really been able to demonstrate an association between those different antigenic variants and virulence of the virus. So we don't see consistency, or we don't have clear evidence that disease caused by 2B is different than disease caused by 2A. But it's been a bit of a lingering question for people. And there was a recent paper that came out that provided some evidence that that might actually be the case. It's very much something that I don't want to say it's an academic topic, but this is not something that you will routinely be testing for. You're not going to be submitting testing looking for the strain or really making clinical decisions that are based on what antigenic variant you have. We will come back to that when we talk about diagnostic testing and about vaccination, because that's where the questions seem to come up most in terms of the impact of the strain. But on a prevention, treatment, general kind of day-to-day, what you need to think about basis, it's a little less critical. All right, so who gets parvo or panleuk? Well, we know that juvenile animals and animals who are co-infected, whether that's a parasitic infection, another infectious disease or they have other comorbidities are the most susceptible to infection and clinical disease with either feline panleukopenia virus or canine parvovirus. There's a little bit of evidence out there, just briefly touching on the difference in the antigenic variants in the dog virus briefly, that maternal antibodies to one strain may provide a bit less robust protection against the others. So there might be some influence there, but generally speaking, we're talking about these younger animals, animals who have other issues. And we see we see a lack of seasonality in the sense that you can have cases all year long, although spring, summer, and in some areas fall are when we see the most cases, probably related to timing of breeding and an influx of more susceptible animals into the population. So while we think about that in terms of being what's most common, we know that any insufficiently vaccinated dog or cat of any age can be infected and affected. There are other hosts that get it, wild dogs, foxes, mink, raccoons, but we're really thinking about this, and for the purposes of this conversation, we're really going to talk about it as it relates just to cats and dogs. So the disease transmission, the virus is found in a number of different bodily secretions, but mostly in the feces and the vomit and to a lesser extent the saliva. So we'll see animals get infected with direct contact. It can be spread by fomites and certainly by environmental contamination, thinking about how resilient the virus is, how long it can persist in the environment. And we do need to be cognizant of aerosolization. It has been documented that inhalation of viral particles can lead to infection. Where that becomes most relevant in a shelter setting generally is when we think about cleaning. It's one of the reasons that we often make recommendations around not using high-powered or high-pressure hosing systems, certainly not directly onto fecal matter because of the risk of aerosolizing that virus. I tend to think of that as being more of a concern with respect to spreading canine parvo as opposed to feline panleukopenia, just because of the way that we usually clean most cats' enclosures, but certainly it could be a risk in either case. And because of its stability in the environment, we know that it can remain infective for a long time, especially if it's protected within organic matter or it's in favorable environmental conditions. So it's shaded, for example, and not in direct sunlight. Just to give an example of that as a case in point, there was a paper out of Brazil where the researchers went and they just collected fecal samples off of the street, normal fecal samples that they found, and they tested them. And about 15% of those came back by PCR assay as being positive for canine parvovirus. And so it's certainly not every sample. Study didn't look at whether or not that virus was infected, but I think it's a pretty good snapshot and a reminder that this is out there. It's out there in the environment, and this is something that dogs and cats are likely to come into contact, which influences what we think about in terms of protecting them. So again, thinking about it being resilient in the environment and being that unenveloped virus, this also means that we need to be really specific with our sanitation procedures and making sure that we're using products that have documented efficacy against parvovirus or other unenveloped viruses. And in some cases, this means also limiting access to certain areas or certain surfaces where that solid sanitation just isn't really going to be something that we can take care of. And we don't want to, or we can't rather, rely on that happening. And so instead, we want to protect very vulnerable animals from potential contamination by going into those areas and limit the risk of contamination in terms of who has access to those. All right, so transmission, we're going to talk just very briefly about incubation and viral shedding. And so the period of time from when the animal is exposed to the virus until they develop clinical signs is the incubation period. That's been reported both for Panleuk and for Parvo to be as little as 2 days and as long as 2 weeks. Although far and away, most of those cases are going to show up 5 to 7 days after exposure. For viral shedding, we know that the animals can shed virus and be contagious to others a few days before they begin showing clinical signs themselves, and for weeks following recovery. It's typically 2 to 3 weeks. It can be longer than that, though. So when animals get exposed and they get infected, the virus attacks rapidly dividing cells. This leads to signs related to where those rapidly dividing cells are generally found. And so the first is in the intestinal tract. And so vomiting, diarrhea, dehydration, the electrolyte abnormalities, and the risk for bacterial translocation, where bacteria in the gut actually pass across that now damaged wall and into the bloodstream, all results from that affinity for those rapidly dividing cells in the intestines. And then on top of that, we see a decreased ability to fight infection related to the bone marrow damage, which is actually how panleukopenia came to get its name, thinking about the greatly diminished blood cell counts that we see there. Now, other serious complications are possible, but they are less common. So things like intussusception certainly is a risk. We think about that in puppies. We do know that there are other potential symptoms, but I'm going to try to keep us on track in terms of what's most common. Oh, I apologize. There's a bonus slide about incubation and shedding that looks like it got out of order. So this is really just saying what I said a moment ago in terms of that incubation period and viral shedding, with a little bit of a visualization on the side to kind of drive home that unfortunate overlap in terms of when animals can get exposed and be a risk to other animals, and when they can actually become apparent that they're infected to us. All right, clinical signs in dogs. I imagine many of you know this very well. Vomiting, diarrhea, which is often but not always bloody, inappetence, dehydration, lethargy, weakness, abdominal pain, and either hypo or hyperthermia. Now, dogs don't, of course, have to have all of these clinical signs. They can have them in various combinations. So it's not that the presence or absence of one precludes a diagnosis. Similarly, in cats, we see vomiting, depression, diarrhea. Inappetence, hypersalivation, cats just tend to drool, or at least I appreciate it more clinically. When you have nauseous cats, the hypersalivation that you'll see is a clinical sign. They'll also get lethargic or seem weak. They can have abdominal pain. And for certain forms of panleukopenia, certain clinical presentations, we can see sudden death. So this is one of the few things that we see where you can have a litter of kittens that seem happy, healthy, bouncing around, doing great, and then a few hours later you find one of them dead in the cage. Somewhat almost paradoxically, we can also see no apparent clinical signs. And so there's a lot of variability that we will see within infected animals and young cats in particular. In terms of cats, I just want to take a moment and point out specifically about subclinical disease. We often think that this is possible in dogs as well. It's probably pretty common in cats, whether that's subclinical disease or mild disease, especially if you think about adult cats, you think about cats who may have partial immunity. There's a whole bunch of studies out there that show really high rates of feline panleukopenia antibody levels, even in cats that aren't known to have a vaccination history. Also in dogs that aren't known to have a vaccination history, which is probably mainly the result of them being infected and recovering from natural infection. And so that lends some support, at least theoretically, to the idea of mild or subclinical cases. Severity, of course, will be influenced by age, immune status, and current infections, particularly if they have bacterial or viral pathogens, because those can increase the turnover rate of the intestinal epithelial cells, and that can further enhance viral replication and cell destruction. We will see cerebellar hypoplasia in kittens depending on the time of infection. And this is because when we think about that tropism for rapidly dividing cells, some of those cells at a certain stage of development are found in the cerebellum, which is what essentially controls balance and coordination. And so the virus can destroy the Purkinje and granular precursor cells if you get either late-term infection of queens or really young neonates. And so I'm sure many of you are familiar with this in terms of that non-progressive ataxia. Usually it gets noticed around 2 to 3 weeks when the kittens are first learning to walk. But there are a lot of other neurologic and ocular signs that are commonly reported associated with that. Now, in utero infection in early pregnancy to the queen can also result in things like fetal death, resorption, mummified fetuses, abortion, and the queen can actually appear just fine. There's a recent paper out that actually suggested an association between queens that had a lot of virus detectable in their bloodstream and really, really high rates of reproductive failure. I do just want to mention, sometimes the question comes up in terms of less common clinical signs. It's not associated with cardiac issues, either in cats or in dogs when they're looked at following recovery. We do sometimes see myocarditis in very, very young pups, although that's certainly much less common than it used to be. For diagnosis, when we're thinking about in the shelter setting, first and foremost, like so many things, the basics go a really long way. And looking in that consistent history and the clinical signs, doing a really thorough physical exam are going to be cornerstones of that diagnosis. And then really, really critical, because of both their reliability, but also their practicality, cost effectiveness, and ease of utility, are using in-house fecal antigen kits. So the performance does vary across manufacturers, and they're not perfect. No test is perfect. You can definitely get false positives or false negative results, but they are a really, really good option to use for timely diagnosis. And that prompt diagnosis, so that we can initiate treatment and improve outcome, and that we can protect the rest of the population, is really key. PCR testing is certainly an option. There are standalone PCR tests that can be sent out, or for most of the common diarrhea panels, it's included in there. It's a little, I don't find that nearly as helpful just because of the turnaround. It's not the first test that I reach for, but it's certainly a helpful one to have in the arsenal. Other things that might be helpful and that are easy and accessible in most shelters, doing a complete blood count or even performing a blood smear in-house to look for that leukopenia. So if you're looking, if you're scanning around at 10x, if you see 4 to 6 white blood cells per field or fewer, or if you're at 40x, if you're seeing less than 3 per field, certainly would be consistent of a diagnosis of leukopenia. So you can see on this slide, there's just quite 3 there, although I also cheated a little bit, and this is not quite the right spot on the blood smear where you'd want to be looking. It is really important that you have an appropriately made blood smear if this is something that you're going to use, if doing a CBC isn't something that you're routinely going to be able to perform. And there is a caveat, whether you're talking about a blood smear or a CBC, that timing of that leukopenia, timing of the nadir, doesn't always correspond with the presence of GI signs, and not every animal becomes leukopenic. So if we think about cats, for example, there was one study that only about 65% of the cats became leukopenic. So it doesn't give you an ability to rule it out, but it certainly, in conjunction with a positive test, in conjunction with a compatible history and clinical signs, can really be helpful in terms of confirmation. And certainly other testing may be helpful to characterize the severity of the disease. There's a fair bit of work that's been done over the years looking for different prognostic indicators for both cats and dogs who are infected. And there are some that are slightly more realistic in terms of serial monitoring. Hypoalbuminemia is sometimes listed as a negative prognostic indicator. Low potassium levels in some studies has been reported as a prognostic indicator, but probably not a lot of the other ones in terms of looking at like reactive protein C are going to be the tool that most of us reach for in terms of trying to prognosticate for the animals.
Dr. Janesco?
Yes.
Blood smear to check for white blood cells for Panleuk. Are you looking at the feathered edge or the middle of the slide?
So you don't want to go too far out towards the feathered edge, and you don't want to go to that area. So you can see my poor technical skills, but I did make it back to the slide. So this one is a little bit too close to the feathered edge. It's just a little bit thinner than you would want to look at. You don't want to look where the cells are stacked and you don't have a single layer. But if you go further out, remember, especially if you use poor technique, you can drag a bunch of those cells. On this slide, and I know it's too small for anybody to see, but we will have the recordings up and that will include the slides. So I put lots of references in at the bottom of them. There's two references that I find really helpful for staff, both in terms of making blood smears and in terms of interpretation. And neither of those are specific to Panleuk or looking for leukopenia, so I think they're a really helpful resource.
Cool. A couple more questions. One is kittens that present with neuroscience to Parvo. Do these typically test positive on a SNAP test?
Ooh, that is a good question. I don't think we know is the honest answer. There's really just a handful of those case reports that are out there. And I think in most of those cases, they were tested by PCR, but I don't think we have the information in terms of whether or not they previously had a negative ELISA or not.
Okay, thank you. And then do you use blood smears regularly as a diagnostic test for kittens? And if you do, what are some low stress ways to get samples on these sick babies?
Yeah, it's a really great question. I tend to use blood smears if I'm kind of waffling, if I'm either not confident that I really think I have a case, the result came up negative, it might be the next thing that I do before I reach to spend the money and send out a PCR sample. Or conversely, sometimes we get animals that it just doesn't really fit. Sometimes an animal gets tested that maybe we would not have tested thinking critically about their clinical signs or history. And I will sometimes use that. Now, I will say I would not use a lack of leukopenia as a criteria to rule it out. So we'll talk a little bit about, just in a couple of slides, about false negative results and the risk trade-off in terms of trying to decide sort of which way to go or which way to believe. And certainly the conservative approach of taking precautions in the event that that animal is infected, I think is really beneficial.
Thank you.
Sorry, did I just cut you off?
No, I just said thank you.
Okay. Was there another one or should I keep going?
That's it.
Okay. All right. So the other thing to think about is, unfortunately, sometimes there is a need or opportunity to obtain a postmortem diagnosis. And so certainly, we talked a little while ago about those unexpected or sudden deaths in kittens. I think necropsying any unexpected death in the shelter is always a good practice. Segmental enteritis is a really classical finding on gross exam. Again, the absence of it doesn't mean that that's not your diagnosis or not the diagnosis for that animal, but certainly that can be a helpful finding. You can still use the Parvo test post-mortem, and particularly if you have a deceased animal, I really think it's important that we look comprehensively and we don't just sort of say, well, okay, you know, we feel like we've rolled out Parvo or Panloop and now we don't need to worry about it, because postmortem diagnosis or a necropsy diagnosis gives us an opportunity that we don't generally have with other diagnostic testing in terms of being able to identify the pathogens and the role that they're playing in disease. And a lot of times it's the most efficient way to get an accurate diagnosis. So when we think about the implications that infectious disease has in a population of animals, this is a really important tool in protecting the health and welfare of the other animals that we're caring for. This is something that you can do in-house and document initial findings and send samples out to the laboratory if you're not able to access a pathologist or a veterinary diagnostic laboratory that can do a complete necropsy for you. So you do want to make sure that you do collect samples, ideally for bacterial culture, potentially for virus isolation. At least for virology, we'll collect samples from molecular diagnostics like PCR, but parasitology and, of course, histopathology. Now, the question comes up, and I apologize if this looks like a little bit of a busy slide, but the question comes up pretty regularly about, well, what about vaccination interfering with test results? Is that a thing? Is that something that we need to worry about? And the answer to that depends in part, well, what test are you talking about? Are you talking about an in-house antigen test kit to use on feces, or are you talking about a PCR sample? And so there's a few pieces of data in the literature that we can pull. I've listed them here that have looked at those scenarios in different animals. And so the first was looking at dogs that had been vaccinated with they were healthy adult dogs, they got vaccinated with a modified live product, and then they checked them by PCR. And they found a shedding threshold of low but detectable in about a quarter of the animals following vaccination. It peaked pretty early on, but in some dogs it could be detected 28 days following vaccination. So if you're thinking about PCR, yes, absolutely. There is certainly a risk if you're using modified live products that could interfere with your interpretation. Another study, very similar to that first one, looked specifically at naive puppies, so not adult dogs who may have previously had titers, but at naive puppies, and they found, not inconsistent with that previous study, low but detectable levels by PCR, even when those dogs didn't have maternally derived antibody prior. But they found no impact on fecal antigen testing. They looked specifically at the witness test in that study, or HA testing that was performed in a laboratory. If we shift to cats, again, in this whole vein of the similar studies, vaccinated cats that were sampled and followed out, as were the dogs in the first two studies that I mentioned. They did find shedding, again, of low but detectable levels in about 30% of the cats. In most of these studies, they tried to isolate what it was. They tried to look and see, is this vaccinal strain? Is this field strain? Is this something that we could actually grow in culture, that it's replicable virus? And those results start to get a lot weaker. Just because of low numbers and sensitivity or threshold of the testing. And then there's the one study that I think everybody is the most familiar with, which is quite relevant and has been around for a while, which is looking at the impact of vaccination specifically on using that antigen test in kittens. And they did occasionally find weak positive results, essentially one out of 64 specific pathogen-free kittens following vaccination, but there was a lot of variability across the test kits used. So one of the most commonly used and recommended test kits had that very low rate of cross-reactivity. Some of the other ones had higher rates. And so certainly, if we're talking about PCR, absolutely. If we're talking about an in-house test kit, you know, probably not. And it's really important to, it's not impossible, but it's not something that seems to happen very often. And so we really want to make sure that we're taking positive test results and thinking about them or interpreting them in context, right? So compatible clinical signs, maybe doing some confirmatory diagnostic testing, especially if you have an animal who breaks relatively recently after coming into the shelter and you've recently vaccinated them on intake. So it's something to think about, but again, not something that I would certainly suggest being dismissive about a result because an animal had been recently vaccinated. All right, I have to pick up the pace a little bit. So prognosis, it varies a little bit if we're talking about dogs and cats, and varies a lot whether you're talking about dogs or cats, depending on what you look at in the study. So certainly we see a variation in prognosis depending on the severity of clinical signs and on the treatments that are provided. I mentioned earlier for dogs, there's been a lot of work looking at prognostic indicators. There are some that are, in my opinion, not really practical for us to think about looking at on a regular basis in the shelter, but low albumin levels, lymphocyte counts below 1,000 per microliter have been associated with lower survival rates, increased mortality, longer periods of time in the hospital. And there's also been some studies that have shown poor outcomes for lower weight animals, including some shelter-focused populations. So for Parvo, what you'll typically see reported is the mortality rate is as high as 90% without treatment, although survival rates in the 40 to 90%, which I know is a huge range, are what's more commonly reported. For panleukopenia, not dissimilar from Parvo, we tend to see higher mortality rates earlier in the course of treatment. Typically higher mortality for younger kittens than for adults, although these are not all consistent findings. There are some studies that have refuted that as well. We often think of panleuk as having a more protracted course of disease than canine Parvo patients, but again, that can vary quite a bit. And we do know, particularly in older, partially immunized animals, that subclinical or really mild infections in cats are certainly possible.
Dr. Janeska, we have a couple questions.
Sure.
So for cats following vaccination, if 30% of adult cats are shedding, should we be holding off on vaccinating new mothers who are nursing to prevent that vaccine virus from affecting the kittens?
So my short answer is no. I think that one thing that's important to look at or to think about in context of those studies, and this is the great beauty of PCR, but it's also one of the great challenges. The threshold of detection, the amount of virus that a PCR test can find compared to what level of virus needs to be present, how much antigen needs to be present for one of those in-house ELISA kits to pick up, varies substantially. In one of those studies, I don't remember which one, but one of the vaccinal shedding studies, they actually did an estimate, and that was that the PCR test was 7,000 times, 7,000 times more sensitive, or its threshold for detection was that much more sensitive than for an antigen test. And so the other challenge about PCR, right, is it tells you presence of viral genetic material. It doesn't tell you if that is active infection. It doesn't tell you if that's capable of being transmitted or causing infection. And so I think we don't have a lot of evidence that shows that it's a problem, and certainly not vaccinating those animals, not vaccinating the queen, for example, if she was naive and were to come into contact with the virus in a high-risk setting, like many shelters are, the risks on the whole generally are going to outweigh, the risks of not vaccinating are generally going to outweigh whatever small risk that might exist because there's some low level in terms of shedding, what in many cases may be vaccinal strain.
Excellent. And then is it the same, do you think, for cats and for dogs in terms of that?
In terms of the vaccination for nursing queens and dams, absolutely.
Okay, excellent. And then there's a couple of questions about dogs as well. So when you are testing for parvo, do you also concurrently check for coccidia, just in case that might be present as well?
Yeah, so I think looking, and we'll talk a little bit in treatment, I think there's really good reason as soon as you're able to treat them orally to administer antiparasiticides against common GI pathogens. So whether you use fenbendazole and empanazole, or you use Panacur and empanazole, I think that is an important consideration, and often we'll recommend doing that empirically, regardless of the findings of the fecal float, just because a whole variety of GI parasites can be shed intermittently. And so a single test, especially if you're doing a passive flotation on a benchtop, may give you a false sense of security that infection isn't actually there.
Excellent. And then one last question about, and actually I might leave this one until the very end. Actually, it's about vaccination. So
okay,
continue on. Thank you.
Well, whoever asked the vaccination question, please bear with us to the end. All right, so treatment considerations, whether we're talking about cats, whether we're talking about dogs, we know that we're always thinking about and striving to balance making those decisions that protect and preserve the health and well-being of the individual animals, as well as the larger population that we're caring for. So if you have an animal that you have either diagnosed or you're in the process of trying to diagnose that you think has parvo or panleuk, it's really important that you have a plan, not just for that individual animal in terms of how are we going to get them treated or where are they going to go, but what do we do for the rest of that population? And so the example that I have up on the screen here, you can actually download this exact file through ASPCA Pro. The link will be in the slides. Provides an example of a response plan to help you walk through those decisions when you have a case that's been diagnosed. Now, I will say this one is a little bit more focused on canine parvo in the sense that it's labeled canine parvo, but it also talks about using serology as a helpful means of trying to categorize the exposed population. And that is not something that is as helpful for feline exposure. We'll talk about why in a little bit. But generally speaking, in terms of thinking about how are we going to care for this individual animal, how are we going to manage the rest of the population should be one of your first steps. Titers can be a really helpful tool when trying to manage an outbreak or thinking about what to do with those other animals in the population. And what it really does is it gives us another tool to help clarify susceptibility and risk. Using these, using them in the way that we talk about using them, really just remember they're guidelines, they're not absolutes. Not everything goes the way that we always think it's going to. And again, none of these are absolutes. It is important that you're using them in animals, and I say dogs just because this isn't something that we tend to use as a tool for cats as much. It's important that you're using them in animals that don't have current or historical clinical signs, because we don't want to confuse infection with their level of protection should they be exposed. The in-house kits, they're less helpful for identifying cats. And this mainly has to do with their sensitivity and specificity. The positive results are fairly reliable, but the negatives are less so. And so that means that you might remove or quarantine inappropriately. There's been some work that's been done trying to improve those test kits. The test had been modified from when it was originally studied to try to increase sensitivity. And it is better, but it doesn't seem to work quite as well as it does for dogs. And in my experience as well, for most shelters that are struggling with a panleukopenia outbreak, the resources just aren't there to do this. And so really thinking about the cost benefit, we often manage those populations, or at least I have managed those populations without that. I'll put a quick plug in for the UC Davis Shelter Medicine Program's Parvo Outbreak Simulator Guide. If you don't have it in your life and you want to get more practice, should you encounter it, they have a really nifty tool that you can go to through their website. You can also download it, and it walks you through and gives you an opportunity to practice making these different decisions for animals within the population. For treatment, of course, we want to really give careful consideration when we're deciding to treat what we're going to do in terms of treatment for animals. And that's really critical for the individual animal and for the larger population. We need to make sure that we have the ability to provide a humane level of care that meets that animal's needs medically and behaviorally. And so that includes having things like adequate supplies, appropriate space and housing, and staffing, whether that's paid staff or trained, reliable volunteer staff. We need to do this in a way that gives us the ability to protect the remaining population. If you're doing this on site, you want to make sure that you have appropriate isolation procedures so that other animals aren't becoming infected as a result of keeping already infected animals present to receive treatment. And we also want to make sure that we don't prioritize treatment at the risk of losing a focus on prevention and wellness care, because that will be a really short-lived approach in terms of the health and well-being of the population. And of course, we want to think about the individual animal's prognosis, looking at all of those factors, and the ability to provide what the necessary level of treatment that animal really needs. This is another, I know it's way too small for everybody to see, but this is another resource that you can download through ASPCA Pro that helps to walk you through making a treatment decision for an individual animal in terms of thinking about an outpatient type of protocol or a less intensive type of protocol. If you will be treating offsite at a veterinary clinic, if it's something that you might be able to manage on-site, or if this is unfortunately a case that you need to think about humane euthanasia. I think tools like these, it's up there as a PDF, but certainly using this as a tool and adapting it as necessary for your organization and population specific circumstances, I think can be very helpful. So we mentioned making sure that you have the ability to provide humane care. And one of the things that's important to note is that regular monitoring is really key, because the status of these animals can change very rapidly. And so part of your treatment protocol, which really requires having, here's another pitch, you can't go to a shelter medicine talk or a shelter medicine conference without somebody spending a little bit of time talking about the power of SOPs. But this really requires having written SOPs that that document clearly what's the description and the case definition, how are you going to manage it, how are you going to treat it. And that includes things like who can initiate and administer treatment, essentially the who, what, where, when, and how, as well as the next steps. What are your intervention points and what happens next? So what are options for further treatment, whether that is more aggressive treatment, a need to change medication, a need to transfer care because more aggressive therapy is needed but can't be managed in-house, or what might be a stopping point at which a decision is made to not pursue treatment and instead to euthanize. Now, I don't think this will come as a surprise to anybody. I think many of us have had quite a bit more exposure to this in our professional careers than we would like. But we know that euthanasia without treatment, often due to financial considerations, and this is thinking in the whole big wide world, right? This isn't just in shelters, this is thinking about owned animals. But treatment without euthanasia, generally because of financial reasons, remains a really common and important death, whether we're talking about Parvo or Panloop. So there's been this whole case series of papers on Parvo out of Australia And they did some surveying. They have a national surveillance system. And in that, they had found an overall mortality rate of 41%. And then they drilled down into that, and not surprisingly, they were able to document that greater socioeconomic disadvantage was directly correlated to higher case numbers and higher rates of without treatment euthanasia. And there was a really strong correlation they found. Australia is a big country like the US, right? So prices vary across the different areas, but they found a really strong correlation between the cost of treatment and the rate of euthanasia without treatment, really underscoring that affordability has sadly important role in this. And, you know, they gave an example comparing it to, you know, sort of average salaries, what that looks like in terms of how many weeks somebody's salary that is. So when we think about that, it really underscores the point that we need accessible treatment for these cases, whether we're talking about cases in the shelter, or we're talking about cases in the community, whether they're coming to the shelter looking to relinquish or they're coming to the shelter and they're seeking care. I'm going to walk us through a few of the papers that have been published for what we do know about really practical and quite effective ways to treat. It's been documented for Parvo. We've got a lot less about Pan-Luke, so I don't want anybody to think I'm intentionally giving short shrift to the cats, but unfortunately this is what's out there in the literature. So I'm going to walk us through a bit of what some of those treatments are and what we've seen from it thus far. I believe we are supposed to go until 2:45. Is that correct, Lena?
That is correct. And a whole bunch more questions in the chat, but most of them are about vaccines. So I was going to ask you one, and then I will let you continue. Is there a difference when you are trying to diagnose Parvo between the in-house kits, for example, between the IDEXX SNAP test or the Witness, in cats specifically?
Yeah, so that the sort of last example of what we have evidence for in terms of published literature for those cases did look at a couple of different manufacturers' test kits, and they looked at 3 different manufacturers. One was IDEXX. I believe the other one was Witness, but I'm blanking on the specifics of the other 2. But yes, I don't work for IDEXX. I don't have any financial or professional affiliation with them, but the IDEXX test kit was the one that had the fewest false positive results. The test kits from the 2 other manufacturers had more kittens testing positive, both in terms of numbers of kittens, but also number of time points that they falsely tested positive.
Excellent, thank you.
Mm-hmm. All right, so let me start on this. And then we'll take a break and we will pick up in terms of translating this more to treatment, talking about prevention, lots about vaccinations, and then plenty of time for questions. So there's really only, I say only, although it's kind of exciting now that there's 4 published papers in the literature that have all come out within the last 5 years or so. I'm really looking at what I'm calling more accessible treatments for Parvo. So there's one in a private practice setting. There's one, and this is the one that I think people are most familiar with, that came out of a group at Colorado State University. There's another one looking at a modified version of the CSU protocol that was specifically from the Pennsylvania SPCA's low-cost clinic. And then just recently, American Pets Alive in Austin published data regarding their Parvo ICU over the last 11.5 years. So we'll walk through those. So the first one, the private practice paper and the CSU protocol one in terms of the published papers came out about the same time. But this one was actually in a private practice setting. So it was a retrospective study that looked back at the results of 130 dogs that had presented to a private small animal clinic over a period of about 2.5 years. Most of these had pretty similar case definitions, so compatible clinical signs, ELISA positive, And this one, as the others did, generally had similar exclusion criteria. So dogs who were euthanized without treatment were excluded from this report, and dogs that ultimately went on to be hospitalized, if owners were able to do that, were excluded from the report. So they ended up losing some to follow-up. They did have 15 that were able to be treated in the hospital and 6 that were immediately euthanized. But they had a really good number of them. And they found a 75% survival rate, at least up to 3 days or longer following diagnosis, with an estimated relative treatment cost for their facility of about a quarter, so 25% or even less, compared to the typical course of hospitalization. Now, this did not have a standard treatment protocol. It wasn't a controlled clinical study. The treatment was at the clinician's discretion, and there were a number of veterinarians in the practice, but they were pretty consistent, at least in terms of what's reported for what they used. And so treatment generally included sub-Q fluids, Cerenia, that should actually say force feedings, for animals who weren't eating, and some specific housing and husbandry recommendations in terms of keeping the animals warm, keeping them housed in a clean indoor environment, making sure that they weren't soiled in diarrhea, for example. So overall, about a 75% survival rate. Interestingly, they found some of their patients were prescribed a high-calorie supplemental feeding, and the mortality rate in that group dropped down to 19%. That's not been repeated in any of the other studies, but it's kind of an interesting point. The CSU protocol that was published shortly thereafter, I think, is the one that most people are familiar with. So this was done out of the teaching hospital. They took 20 dogs, treated them as inpatient, 20 dogs treated as outpatient. And they actually administered, all of the dogs were in the hospital, but it was sort of like the typical intensive inpatient treatment, or this treatment that could potentially be administered by owners at home. And they found no significant difference, statistically significant difference in the survival rates of those two groups. 80% in the outpatient survived, 90% in the inpatient survived, or in the duration of clinical signs. So it's not like one group got better faster than the other. The dogs were evaluated for eligibility. They got IV fluids for volume replacement and electrolyte and glucose adjustments based on their labs. And then they were converted for the outpatient group over to sub-Q fluids, divided into 3 times daily doses. They got Convenio once, they got Cerenia every 24 hours. They had rescue protocols in terms of additional analgesics with buprenorphine or additional antiemetics, and again, syringe feeding. They did supplemental glucose or potassium based on labs, and they did that with Cara syrup and Tumul K. And again, they did transfer dogs out of the outpatient into the inpatient if they met the case definition of failure of treatment, but that was only 1 dog out of all of them. So really, again, another exciting data point of what is a higher success rate and survivability than what's often quoted in the literature, and certainly comparable to the very intensive care that might be seen or could be provided at a veterinary teaching hospital. I'll just do these last 2 quickly and then we'll take a break. So the next study that came out that was published was looking at an urban low-cost shelter-based clinic through the Pennsylvania SPCA. They had 95 dogs in that program, and they were treated with a modified CSU protocol, and essentially the modification of that protocol, which they very handily published. That is not up there with the intent that anybody could see or try to read that, but that is the treatment algorithm that they published in the paper. And we'll have the links for all of this. So if you get the paper, you can find that exact protocol in the paper. That one I think is particularly helpful because they modified it down to be feasible as a twice daily treatment to try to reduce some of the barriers in terms of owners coming back into the clinic and administering treatments. And they found an 83% survival rate. They saw that longer illnesses, a longer time of illness prior to presentation, perhaps because those were more mildly affected dogs, or increased body weight during treatment were associated with survival. They found that hypothermia on presentation was negatively associated with survival. Now, all of these, I should say, do have a little bit of a selection bias in the outpatient protocols, in the sense that they all had to, they all included dogs who had to be stable enough to receive this treatment for which this treatment was appropriate, and inpatient treatment was not financially possible. So there is some selection inherent to this in terms of more mild cases. And we do know that less severe cases are more likely to survive. But still, obtaining a survival rate that's really comparable across these different settings, whether we're talking about academia, private practice, or a shelter-based public-facing clinic, really is, I think, incredibly exciting and encouraging, and especially looking at sort of the direct head-to-head comparison. And then that last paper that I mentioned was looking at records or data from over 5,000 dogs that were treated by APA over an 11.5-year-ish period. They had a reported almost 87% survival rate. Dogs who did die died typically within the first 5 days. Generally took them about 7 days. About $300 and 9 or so volunteer hours to treat them. Again, there's less specificity in this paper in terms of exactly how the dogs were treated and outcome, because it covers such a long period of time. There were variations in the protocol, and there were some points of missing data. But again, some really encouraging data. So I'm gonna stop with that. We'll take a break and we'll pick up after the break, talking about the implications that this has for us in a practical sense of how we treat animals and how we can extend care. And then we are going to go into prevention.
Excellent. Thank you so much, Dr. Donesco. Hey, everybody, we'll be back at 4 o'clock, or excuse me, 3 o'clock, and go until 4 o'clock. So sorry you get a little bit of a shorter break, but then you can have more time later at the end. So thanks very much. I hope you come back in about 10 minutes.
Thanks, everybody.
Hello, everyone, and welcome back. So this is the second hour of the Canine and Feline Parvo lecture with Dr. Stephanie Janesco of the ASPCA. And before we keep going, I was hoping you could answer a couple of questions that popped up in the Q&A. So one of them was whether all of the studies that you just talked about, that were all about the outpatient parvo treatment, whether they had, let's put this in a politically correct way, if their methodologies and interpretations were equivalent and or well done.
Now I'm going to have to think of an appropriate way to answer that back. There is a lot of variability across those studies, both in terms of the approach that they took. So the, hang on, I'll flip back just for a second. I think I'll flip back for a second. So when we look at these four across the top, right, we've got one that's happening in a private veterinary clinic, and they're going back and they're doing a retrospective off of the medical results. There wasn't a consistent protocol that was put in place. You know, there's inconsistencies in information. Not everything is done the same way or tracked the same way. That is also true as well. I think particularly if you look at the most recent, the APA study, over the course of sort of 12 years of treatment, where they were capturing data, how they were capturing data, of those 5,000 dogs, how many records they had to look at specific things. So they didn't have the full 5,000 to look at individual treatment records, for example. So there's a lot of variability that comes particularly when I think we run into the messiness of real life, where we've been doing something that wasn't necessarily set up prospectively or a priori as a research study, as opposed to something that's more structured, like the CSU study that really was prospective. Dogs were randomly assigned. They had very clear, consistent protocols, a lot of consistency to really try to dig down to that. So I'm not suggesting that we look at any of these. They're all still really pretty small studies. And we know that there's a lot of variability on any one sort of slice of the topic when you look at the literature. So I wouldn't look at any of these as sort of a be all and end all. But for me, when I look at them across a couple of different settings, there's some things that really stand out to me in terms of consistency with what was used sort of generally across the board, right? Thinking about relatively infrequent treatments, administration of treatments subcutaneously, good attention to controlling vomiting, good attention to early enteral nutrition, those types of things. So we see those consistencies there. And then also just looking across the board at the reported survival rates. Again, knowing that there is a survivor bias in terms of who is eligible for these protocols, but taken as a whole, I think what these really say to me is, you know, we can feel pretty comfortable if we're setting up a solid protocol and we're monitoring the animals appropriately and selecting patients accordingly, that this can be a really important life-saving option that, you know, 5 or certainly 10 years ago was probably not something most of us were thinking about.
Excellent, thank you. And then one more question about testing, and this is sort of my bad because I thought the question was about dogs. But for cats, is the period of vaccine virus shedding the same as for dogs? So for dogs, you said it was 3 to 28 days and was more likely to see it around that 3-day mark. Is that the same for cats?
So is this looking, this is a question specifically about that shedding that's picked up following vaccination, not shedding following natural infection? Yeah, so there's some variation, and part of that is how long the investigators set the study up. So those PCR studies investigated out to 28 days. I believe the 3 manufacturer test kits for the kittens who were vaccinated looked out to 14. So again, as in so many things, they're not exactly apples to apples, so it's a little difficult to answer that directly.
Thank you.
Mm-hmm.
All right, that's it for questions for now.
All right, so let me skip back to the other side of these. To what I was just saying a moment ago, in terms of thinking about those kind of cornerstones of treatment, and these are not new cornerstones of treatment. We've gathered new information on them and their relative importance over the years, but they're not necessarily new in terms of being particularly novel ways to treat parvo. But whether we're talking about ICU, really aggressive care for very fragile animals, or an outpatient style treatment protocol for more stable animals, we have a lot of the same cornerstones in terms of addressing dehydration, hypoglycemia, and electrolyte imbalances, treating those underlying or concurrent illnesses, especially doing things like treating for any parasitic infections they might have, really taking efforts to prevent them from becoming septic from the damage to the integrity of the GI mucosa, as well as their hampered immune system because of the virus's propensity to attack those rapidly dividing cells in the bone marrow. Certainly alleviating pain and discomfort, and stopping vomiting and starting feeding. Now, whether you're talking about an intensive in-hospital type of setting or not, there are those consistencies, but one thing that stands out across all of those papers, and that I think is really important to underscore, is that even for those more stable animals who are good candidates for a less intensive treatment protocol, diligent supportive care and monitoring are still required. So this isn't a like, oh, we don't have to worry about it, and we're all good and we can sort of send them on their way and, you know, just have somebody come back in a week or so. So with that, thinking about these sort of cornerstones of treatment, certainly we've talked about the damage that the virus causes to the intestines and how that leads to vomiting, diarrhea, dehydration. So it's really important that we're keeping up with that. Being dehydrated makes you feel lousy, but it's also got really important implications for the well-being and health of the rest of your body in terms of organ function, mentation. We know there was a recent paper, so I tend to think of, or I think we've classically tended to think of some of those more severe sequelae to dehydration, so hypovolemic shock, right? And then further damage that can cause. But we know that dehydration can predispose to kidney injury. And there's been a paper that's actually documented that. So they looked at a whole bunch of renal biomarkers and found that even though you can't pick this up with routine monitoring of creatinine and BUN, which makes sense because those aren't going to get altered until we've lost really 3/4 of our functional renal tissue. But we know that there's tubular and glomerular damage happening. So really making sure that we're staying on top of that. This hasn't been assessed on any type of long-term basis. On the human side, there's evidence that that's associated with a higher risk of long-term renal outcomes, with even a single episode of acute kidney injury being problematic. So I think it just adds another reason and sort of underscores the importance of making sure that we're keeping up with those fluid needs in the faces, particularly of ongoing losses, but also what initially is usually diminished voluntary intake. And then it's attending to all of the other electrolyte abnormalities they may have. The CSU protocol, they found that hypokalemia was so prevalent, they actually suggested that, you know, it might be helpful to just consider putting everybody on standard supplementation prophylactically. And they did that with Tunnel K in a really accessible and cost-efficient way. So hopping over to treating underlying and concurrent illnesses, definitely we want to get rid of anything to the extent that we're able that might exacerbate clinical disease. Certainly those other bacterial pathogens or parasites that can increase GI turnover or virus replication. And so treating for parasites as soon as possible is really important. Flipping down to preventing sepsis, broad-spectrum antibiotics really are indicated due to the immunosuppression and the likelihood of bacterial translocation that we see in these patients, whether we're talking about cats or dogs. So there's lots of factors that should go into antibiotic selection, thinking about, are you picking a time-dependent or a concentration-dependent concentration-dependent drug? Is it likely to do the job against the pathogens that you're really worried about? What are the clinical signs that the animal has? How severe are they? What's their overall condition? How are you going to administer it? How's it going to get absorbed? And so we often think about the kind of classic broad spectrum treatment with ampicillin and a fluoroquinolone or an aminoglycoside. I'd really try to stay away from the aminoglycosides, given what we know about the risk of tubular and glomerular damage. But one thing that's really nice, and you'll see this as a consistency across the protocols, is that Cerenia as an extended spectrum cephalosporin is effective against gram-positives and gram-negatives. And the ability to give it sub-Q with its inherent long duration of action is really, really beneficial. If we think about, just to go into a little bit more detail, about alleviating pain and discomfort and stopping vomiting and starting feeding, I'm going to talk about those together because I think they're really hard to tease apart. And so some of you, some of the veterinarians in the audience may remember this meme that was making the rounds, I was going to say a few months ago, although it's probably a couple of years now, about Cerenia being the wonder drug that it seems to be. But in terms of antiemetics, there's been a couple of studies, whether you look at metoclopramide or ondansetron or Cerenia, they've all been shown to be equally effective in reducing the frequency and severity of vomiting. And so with that, the fact that there's something that I can give sub-Q that's easily accessible automatically bumps that up on my list. Plus, the fact that we know it's going to provide some visceral analgesia is another reason for me that would be my go-to. Certainly some animals will require rescue antiemetics or they will require additional pain relief. So if you do need to reach for something, buprenorphine is a common one. The opioids can lead to ileus and they can actually result in vomiting. And so if you are going to do it, going for a partial agonist like buprenorphine instead of a pure mu like hydro or fentanyl is probably preferable. Nutritional support is really important. All of those protocols across the board where they included the data did talk about getting vomiting under control and getting calories in the form of food into the affected animals. And so it's really fallen out of favor to withhold food or water until some arbitrary period of time after the vomiting subsides. There's lots of reasons that had been recommended. But what we've actually seen when it's been looked at is that early enteral nutrition, so feeding by mouth, resulted in quicker clinical improvement and significant weight gain for those animals in that group compared to a group that was more traditionally fasted. And so getting them over vomiting is a huge win and a huge step in terms of continuing treatment. On top of just that absolute benefit, providing food we know promotes normal peristalsis, so that can help with some pain relief. It improves enterocyte health, which in turn can help reduce bacterial translocation and limit inflammation. So it's a really important thing to have as part of the treatment protocol. Now, I know I have a dog with an NG tube up his nose. That doesn't mean that you need to do it that way. But even with syringe feeding, a lot of the negative effects that we associate with sometimes force feeding can be alleviated by giving smaller amounts more frequently. Typically, we say digestible, low fat, often a recovery kind of diet. And so when do you do it? Really, the recommendation is to start as soon as you fixed your fluid deficits and adequate GI perfusion has been restored. So functionally looking at mentation, heart rate, pulse quality, mucous membrane color, and capillary refill time and body temperature all having normalized would be good signs to go ahead and start eating in conjunction with your antiemetics. There's lots of other therapies that have been tried, everything from granulocyte stimulating factor to interferons, and probably if you name it, somebody has tried it as a treatment for parvo or panleukopenia. So I'm not going to get into all of those now. I do just want to mention Tamiflu because it's one that comes up less frequently now, but we still get questions about from time to time. There have been anecdotal reports around the use of Tamiflu for parvo patients that were promising, but they weren't backed up, at least in terms of what was published when people dug in to investigate it. The dogs who received it in the one study, they gained weight and they didn't get that same drop in white blood cell count, but they actually had no difference in their clinical signs or in their survival. And it's still, at least for me, as far as I'm aware, we don't really understand what the mechanism of action would be. This is a neuraminidase inhibitor that's typically used for influenza because it stops progeny virus from getting out and infecting new cells. So not exactly a clear translation to parvoviruses. But taken as a whole, given this lack of efficacy and the fact that we really don't have pharmacokinetic studies, and there's some public health concerns with widespread use of this drug in animals, it's really not recommended for treatment. Now there is one, I have not personally tried this in any panleuk or parvo case that I have treated, but it's been popping up in the literature, and that as a potential easy, low-cost, practical treatment, that is fecal microbiota transplantation. So this is well documented and well utilized in people, typically for treatment of C. difficile infections, but it's starting to get more attention in veterinary medicine for a whole variety of enteropathies. So this has been looked at specifically for parvo puppies. They did a randomized clinical trial of puppies either got assigned to standard treatment, which is essentially what we've talked about, or standard treatment with transplantation from a donor dog. And they found a significantly quicker resolution in diarrhea. The graph on the slide, the red bars are the dogs who got the transplantation, the blue bars are the dogs who didn't. And you can see that really dramatic difference in the dogs whose diarrhea resolved within 48 hours and certainly within 96 hours. And so that, you know, is beneficial from a whole bunch of standpoints, right? It helps keep costs down because it can help get them out of the hospital faster. It can help, or out of treatment faster. It can help reduce the euthanasia, particularly for economic reasons. And most dogs only needed one of these procedures. They'd set the study up that they could do it up for 5 times, but they didn't actually need to. It was a relatively small study. It wasn't statistically significant, but the mortality tended to be lower in the transplanted group. So I'm really curious to see where this goes. I suspect this is something we'll be hearing more about in the future. Following
Dr. Janesco, quickly, a question, if you don't mind.
Yeah.
Janine is wondering why using big gun fluoroquinolones for parvo puppies, since there might be some effects on articular cartilage, excuse me, and whether or not ampicillin and metro in combination might not sort of give you the same effects and be less of concern for resistance.
Yeah, it's a good question. So I would not, and I think one of the things here, right, is balancing what you're facing. So I would reach for convenia if I had a stable enough animal that I felt I could use that with. If you really have a debilitated animal, very severe clinical signs, then sometimes they really do need those IV antibiotics, and typically ampicillin, whether it's a fluoroquinolone or an aminoglycoside, and sometimes even adding in metronidazole on top of that is necessary. There's some data around the efficacy of metronidazole and E. coli specifically about whether or not it's in anaerobic or aerobic conditions that I think it gives us a little bit of pause about how helpful that actually would be. And I think for sure, right, fluoroquinolone use, it is a big gun, and it's not without potential side effects, whether that's cartilage damage in young growing dogs, particularly large breeds, or the risk of retinal destruction in cats. But I think if we're looking at an animal where we think they're going to die without it, and that we don't have another viable option, I would consider using it. Great question.
Excellent, thank you. And then Fiona is wondering about whether you have any idea about criteria for donors of the fecal transplants and how best to give them. If that's something that you might be able to address.
This is so interesting. It's a little scary. It's not super regulated on the human side, or super prescribed on the human side. And so it's really not. There's just been some work that's come out within the last couple of years proposing some standards for animals. Generally, they're pretty rough. So animals who are, if they're overweight, underweight, if they have any type of concurrent illness, if they've not been vaccinated, they're off the list. And similarly, most authors suggest if they've had a recent history within the last few months of antibiotic use, that they're not eligible because of the impact that antibiotics may have on their own microflora. They can't have a history or current clinical signs of GI disease. There's usually some enteropathogen screening that happens. For cats, they usually recommend that they're retroviral negative. But it's really a bit all over the map. They do describe the donor dog in that paper, and it wasn't particularly intensive testing. So I think there's not been appreciable complications that have been reported from fecal transplantation. Most of what's been looked at is in dogs. There's been a couple of case reports in cats, but I think we just don't know.
Excellent, thank you.
Keep going?
Go right ahead.
All right, working on getting to vaccines. So after recovery, dogs generally recover 3 to 10 days of treatment. Cats can take a little bit longer, again, depending on severity of clinical signs, form of disease. Viral shedding, we talked about way back at the start of the first session, usually stops within 2 to 3 weeks. In my experience, they stop shedding most of the time, even well before that, but they have been reported out to 6 weeks. So oftentimes after they're clinically recovered, we'll recommend doing, and I usually reach for a SNAP. I don't typically do a PCR, either 1 or 2, to try to give some confidence that they're not shedding infectious virus that might be a risk to other animals in the population. Certainly for dogs, bathing and drying them thoroughly. I fully understand what bathing cats entails, and so it may be some diligent attention in terms of wiping paws and around their perineum. Cats also are really good groomers. I don't think we know how necessary this is for cats versus dogs, but just try to eliminate any virus that might be hanging around on the fur. You do still want to vaccinate them as usual, not because we worry about them getting reinfected with Parvo or Panleuk, but because those vaccines have other important components that we want to make sure they get protected from. And then we want to keep them moving on their pathway, right? We want to get them to adoption or transfer back to the owner or wherever they're going. So I don't know how many of you were able to join Scott Weiss's keynote on Friday, but he had this great slide about a Swiss cheese approach in terms of prevention, and how none of the things that we do are perfect, but when we line a whole bunch of them up, eventually we create enough of a protection where we build in essentially stopgaps. And so I often think of infectious disease strategies as sort of like plan A to keep them from getting exposed, and plan B to have things work out as well as possible when plan A inevitably fails. But fundamentally, we're looking at a combination of efforts. And for Parvo and Panleuk, like so many of our other infectious diseases, like we've seen with COVID and respiratory pathogens in people, we have a relatively limited number of tools in our toolbox, but the good news is that they work for a lot of infectious diseases. And so we are going to spend a good chunk of time on vaccination, but I would be remiss not to mention some other really key, and I would argue, if not more important, then certainly as important considerations than vaccination. And that includes operating within your capacity for care, reducing length of stay, recognizing and responding to illness promptly, maintaining excellent sanitation procedures, because this is something that can remain in the environment and serve as a potential source of infection for future animals, and then following recommended vaccination protocols. The bottom line is we know effective population management saves lives, and operating beyond capacity for care is a bad idea for so many reasons, which literally is a talk in and of itself. But we also know it's a major risk factor for disease outbreaks. And we've seen time and again for a whole variety of just different illnesses that longer lengths of stay in the shelter increase the risk of exposure, and can be documented to increase the incidence of illness. So when we have crowding, we can get into this negative cycle or this negative spiral of all of these factors that are challenging in shelters and a shelter population to begin with. And so we get increased disease transmission, increased animal stress, increased staff stress. All of that diminishes welfare. It further compromises our capacity for care. That in turn tends to diminish customer service because we're too busy worrying about the animals than to do something like process adoption applications or have a counseling session to find the right match for that person and that potential animal, all of which feed back into each other to increase length of stay. And so effective population management, in my mind, to boil it down to a nutshell, is sort of flipping ourselves out of that negative spiral and into that positive circle where we're able to meet the animal's medical and behavioral needs, their physical and behavioral health needs, so we can provide improved care, have healthier animals, get them placed more quickly, reduce those sheltering costs to turn around and use more of those resources for prevention or for helping other animals, because we have fewer animals who are actually in the shelter with us at any given time. Sanitation is important for control of parvo and panleuk for the reasons that we talked about. So you want to have really solid procedures, having the appropriate tools and techniques, the right products, the right equipment. You want to make sure that you're using disinfectants that have been proven independently to be effective against hard to kill unenveloped viruses like parvo. And those products need to be applied correctly at the right dilution for the right contact time. Many of them require cleaning. Pretty much every disinfectant needs to be applied to a relatively clean surface. Some of them are more or less inactivated by organic material than others, but really doing that well. Having housing that meets the needs of the animals and facilitates care, labeled and dedicated equipment, minimizing the risk of transmission in the facility, thinking about how you move through the facility, who's doing the caring and cleaning and what PPE they're using, hand sanitation, and then we talked earlier about sometimes we do have to restrict access to hard to sanitize surfaces or areas. So the young puppy with diarrhea is not the dog to go out into the grassy play yard, for example. We can be our own worst enemies. And so this is really, really important in terms of hand hygiene and appropriate PPE use. I will say foot baths are generally not a great idea. They're not reliably effective, and they can actually help spread disease. So where transmission via footwear is a concern, and that certainly can be the case with parvo, using dedicated footwear that can be cleaned and disinfected, or disposable shoe covers are better choices and ways to go. There's two really great sanitation webinars and then a whole bunch of other resources that are up on ASPCA Pro. Dr. Chimki Aziz did both of these. They're a really helpful resource if you're looking for more information. And now vaccination. So Parvo is considered a vaccine preventable disease. These are amongst the best vaccines that we have, and they will induce what's called sterilizing immunity. So given to an animal with a functional immune system who's able to respond with enough time to respond before exposure, these vaccinations can actually prevent infection, as opposed to the situation that we see with other vaccinations where they just limit the severity of clinical signs or the extent or duration of shedding. So I said a couple of key things in there in terms of those caveats about when they can prevent infection. And that translates to some reminders for us in terms of how we use vaccinations. So we need to give them as close to the time of intake as possible, and even better yet, before they step foot in the shelter, so they have time to mount an antibody response and a cell-mediated response before they actually need that. The modified live products need to be kept refrigerated. They need to be reconstituted, and that needs to be done just prior to use. These are not the ones that you can mix up and stick them back in the fridge or leave out on the counter if you want them to be effective. So the recommendations for dogs and cats are similar. For dogs, it's a distemper adenoparvovirus at or prior to intake. Starting at 4 weeks of age, and this is looking specifically in the shelter setting because of the high risk of exposure and impact of not having more aggressive vaccination protocols. For adults, the current AHA guidelines recommend a booster 2 to 3 weeks later. For puppies, they recommend a booster every 2 to 3 weeks until they're 18 to 20 weeks old. And I would really underscore that 20 weeks to you of not stopping until you get them beyond 20 weeks. And if you have animals in a shelter setting, particularly if you have a high risk or a high rate of parvo, that you're doing that vaccination on an every 2 week interval. All of this is about weighing the risk of exposure with the risk of vaccination. But that is why the protocols for shelter animals are more frequent and start at a younger age than those for owned pets do. This is a core vaccine. You don't want to just assume that they're protected. So this paper has been out for a while. This was looking at the prevalence of positive antibody titers to distemper and parvo for dogs coming into a Florida shelter. And you can see these are the dogs without what were judged to be protective titers. Parvo's in blue, distemper is in black. You can see there's a pretty sizable number of unprotected animals. That goes down as they get older. So certainly the youngest are the ones that we see the greatest risk for. But this is not something to assume, well, just because they've made it to you, they've somehow been vaccinated or recovered from parvo. We also see the opposite. We do see in some populations very, very high levels of antibody titers, despite no obvious history of prior vaccination. There was a recent paper looking at dogs in Ecuador. Most of those dogs were, or about half of those dogs, I think, were reported to have not had any prior veterinary care, but almost all of them had positive titers, presumably because of a little bit of that kind of survival bias where they're around to be sampled because they've lived through and recovered from natural infection. For cats, for panleukopenia, very similar. We're talking about the FVRCP vaccine at or prior to intake. Again, starting at 4 weeks of age. Boostering 2 weeks later for adults, and for kittens, every 2 weeks until they're 16 to 20 weeks old. So AHA puts out, the American Animal Hospital Association puts out the canine vaccination guidelines. The most recent ones are 2017. AHA, in conjunction with the American Association of Feline Practitioners, put out the most recent feline vaccination guidelines, which were updated in 2020. And you can see the feline ones are slightly more aggressive in terms of the booster frequency. But again, I would really underscore that 20 weeks to all of you. And just like with dogs, this is a core vaccine for everybody, and we don't want to assume that they are protected. This was looking at cats going into a Florida animal shelter, and the number of cats who had protective antibody titers. So we see an increase as they age, but certainly when they're under a year, the majority of them are not protected. And there was no good way to try to figure out who these were. Health status when they came in, vaccination at shelter admission, where they were coming from, none of that was associated with being able to predict whether or not they'd be seropositive. So where that 20 weeks comes in, there's a pretty good chunk of data out there that maternal antibodies can persist for a surprisingly long period of time in not most, but some animals. And so this was a study looking at specific pathogen-free kittens who had either high or low levels of maternally derived antibody, and then how they responded to vaccination at 8, 11, and 14 weeks of age. So what is sort of most interesting here is they checked them 3 weeks after the last vaccination. So if you look at the 17-week mark, you can see that range that's reported is 0 to 640. And that's because 52% of them they did better with modified live vaccination in terms of overcoming maternally derived antibody at 8 weeks. But this one right here was that 40% of these that had their last vaccine at 14 weeks did not have a protective antibody titer. And so that's where that need to vaccinate longer comes out from. These are some pretty old papers, but data looking at how quickly administration of a modified live vaccination can generate an immune response. And so documented within about 4 days for distemper for dogs and 72 hours for Panleuk for cats. So we don't want to delay at all. We definitely want to get them in as soon as possible or before they come into the shelter. But they will respond quickly, and a lot more quickly than many of us were traditionally taught in vet school. All right, do the vaccines prevent all of the strains? So this has been a bit of a ongoing question, and if you do a literature search, you would be forgiven for thinking they must not, because you can find all of these papers about Parvo and vaccinated dogs and CPV2C and vaccinated dogs, despite the fact that there have been a few studies showing that the existing vaccines do protect against infection with the new antigenic variants, 2C in particular. And so that's been done both under experimental conditions and with a challenge with a field strain. But there's a whole bunch of these, right? And so where does that come from? Well, if you dig into them, most of these papers, and I'm just sharing this one as an example, look at vaccinated dogs that they're categorizing as vaccinated, that have clinical signs suspicious for parvovirus. And then they go and they test them by PCR, and then they go and they do this sequencing to try to figure out what strain that they have. But for this one, so they started off with 78 dogs. Only 50 of the 78 were PCR positive. They didn't see any difference across the different strains. But then when you drill down into those 50, 29 of those 50 were puppies who were under 4 months of age. So they immediately, in my mind, are off of my list, not in terms of worrying about for their individual protection status, but in terms of worrying about, oh, maybe our vaccines aren't working, because we would totally expect that those puppies could have had maternal antibody interference and not responded. And then when you look at the rest, the infection mostly occurred in these dogs within a couple of days after vaccination. So it's questionable if they were exposed at the point that they were vaccinated and the vaccines just never stood a chance. And many of these dogs also only had one vaccination. So this is an adaptation of a figure that appears in one of these papers, sort of questioning how well the vaccines work against the circulating strains. And despite that, they fully emphasize, and this absolutely lines up with our experience and my personal experience, that the most common reason that we see quote unquote vaccination failure is because of maternally derived antibody interference. Certainly, at least in my experience in the shelter setting, the next on the list would be incorrect or improper vaccination storage. And there are some animals who will be non-responders. We don't really know exactly how many they are, but they're dogs or cats that we don't have any reason that we would expect them not to respond to a vaccine, but they just don't ever mount a detectable response. This is just another different way of looking at it. This was a paper, this one's out of Australia, looking at differences between strain in terms of vaccination failure. But you can see the x-axis is age at the time of their last vaccination, and then on the y-axis is frequency. And almost all of the cases, 80% of them occurred when the last vaccine was administered between 16 to 18 weeks of age. Half of them were when the last vaccine was given to less than 10 weeks of age. And so it's really, really clearly documented in the literature. There's similar documentation for cats that not vaccinating out to that later age is a very common and significant risk factor for quote unquote vaccination failure and subsequent disease. And this is because maternal antibodies get in the way. They're really helpful when you're a puppy or kitten and you're firstborn and you don't have that functioning immune system to protect you. Antibodies that you ingest from mom through colostrum when you're nursing provide an invaluable life-saving defense. But they go away, and they go away at a predictable time. So they have a specific half-life. It's about 10 days for kittens. It's a little bit longer for puppies. And so when they will drop down to a level at which they don't protect you from infection is going to vary depending on how high the titer in that individual puppy or kitten was to start. So what level of antibody they started with. But there's no way to know that from looking at an individual animal. And so what happens is we know that the level of antibody that protects from infection is not the same as the level of antibody that will block response to vaccination. And so this creates what's known as an immunity gap, or a window of susceptibility that's usually a couple of weeks long, where the maternal antibodies can't protect them from infection, but they're still not responding to a vaccination. And so this is the reason that we give so many vaccines, and that we give them out, as I mentioned previously, until we get past the point where we really expect that there aren't going to be maternal antibodies hanging around any longer that would block that puppy or kitten's own response to vaccination. So 20 weeks. Now, in terms of counteracting risk, we think about vaccination for protecting individual animals, but absolutely it's about increasing herd immunity as well. This is a map from a paper that was looking at GIS maps compared to where animals who were coming to a local shelter with or without antibody titers against parvo and distemper were located. And so in this one, it might be a little hard to see. The dogs that have protective antibody titers are the little blue dots, and that's layered against the intake in the community. The red circles are the shelter. So like in many communities, there's high intake immediately in that surrounding area. But then they went on and they created census, or they used census tract data to create these maps that then looked at areas of low income and low access to veterinary care to really demonstrate the overlap with where these dogs are coming in, where we are seeing animals that don't, I just pulled out parvo, that don't have these protective levels, and what we can do with that. And so there's some good evidence out there in terms of the risk of unvaccinated animals and increased, as we would expect there would be, an increased likelihood of cases. So this was in the Southwest US. Shifting to Australia again, there was a study there looking at rates of domestic dog cases when they were able to detect Parvo cases in the wild dogs. So they have a circulating or free roaming population of dingoes in Australia. And when they looked at zip codes where you had wild dogs who had been tested positive, you were like 9 times more likely to see cases in the domestic dogs. They saw something similar looking at cats. Vaccinated cats were much more likely, big surprise, than unvaccinated cats to have titers. But when they came from areas that were less socioeconomically advantaged, and there's some specific government indicators that they looked at there, the cats were basically, you had more cats with protective titers if you were in more affluent and well-served areas. So not necessarily surprising, but some really specific points in the literature, all of which I think sort of points to us, well, so what else can we do, right? And targeting vaccination clinics to geographic areas that have fewer veterinary resources, areas that might be based on a variety of metrics defined as low income or low access, can be a really important way to target and maximize resources. We don't know what the critical level of vaccine coverage is to stop outbreaks and transmission, but there's certainly an individual benefit to the animals who get vaccinated and potentially to the larger community. And if you wanted to drill down into that even further, probably focusing on those young animals under a year of age would further increase the ROI, you might say. But vaccines are not perfect. They are a tool in our toolbox, and used in a vacuum without attention to other strategies, they're not likely to be as effective. And they're also not the only tool that we have. So just as an example, this was a recent paper looking at parvo diagnoses in puppies that went through a large-scale ground transport program. This is the ASPCA's relocation program. So they looked at almost 4,100 pups and found an incidence of parvo diagnoses that were reported following transport of just 2.5%. And that incidence was the same if puppies got 1 vaccine or 2 vaccines prior to transport. And there was no difference in the incidence based on the amount of time that they spent at the source, the time from vaccination to transport, and there were some other factors that they looked at. So it was really, really infrequent, and I think emphasizes the importance of looking at all of the strategies and all of the steps that we're taking together, and not relying overly heavily or inappropriately on vaccination. There's one other thing that I wanted to mention. Some of you may have seen this paper. It came out earlier this year, and it was looking at the potential COVID impacts on parvovirus incidents. So this was in Austin, looking specifically at the cases admitted also, again, to APA's parvovirus ICU. And what they found, this graph is a little messy, but that gray period sort of shaded down the middle was the lockdown in Austin associated with COVID in 2020. And it's a little easier to see on this next slide. So you can see here, 2019 compared to 2020, there's a giant dip, and then it sort of goes back up. The graph on the left is 19 to 20, and the graph on the right is the aggregate average of the prior 6 years compared to 2020. But it raises a really interesting question of, you know, what else could we do? What are the things that we do and maybe we don't realize, or the situations that we put dogs in and we don't realize, that are impacting disease spread for something like parvo, this one's parvo specifically, that can be really resilient in the environment. And so there's some discussion in the paper about some practices or restrictions that might help to further reduce disease incidence. So I think it raises a really interesting question, and behooves us to think more broadly about what else could we do to lessen the frequency of illness, and how do we do that? What are things that maybe we thought off the table, like who would have thought everything would shut down for COVID, but we did. So are there other things that we should consider trying that maybe we haven't entertained before? At the same time, I think we need to balance that. And I don't think my slide flipped. Okay. At the same time, we want to balance that with the other impacts that come. So to take the COVID example, there's been lots of work looking at impact on people and on animals in every shape and form over the pandemic. So this is pulled out of a couple of different papers, 2 out of the UK, 1 out of Spain. But so basically we look and we see strict lockdown measures are implemented, consistently seeing dogs are going on fewer walks. They're meeting fewer or no other dogs when they're walking. Owners report that they're actively avoiding places that are likely to have more dogs. And if they do happen to come across another dog, they're making greater efforts to prevent the dogs from interacting with others. And so that could absolutely reduce incidence of disease. But there's a flip side to that. And for this specific example, that includes things like less of a chance for physical health benefits for owners and for animals, reduced opportunity for human and social contact. And I think really being mindful of the impact that this has on the whole animal is important, because in this grouping of studies, in this case, 62% of the owners had noted that the restrictions had a negative impact on the dog's quality of life. And so I think the trick in so much of what we do is not only balancing individual animal and population level considerations, but it's also balancing everything about that animal and making sure that we are not forgetting to protect both physical and behavioral health. You've probably heard this before. If you've heard me talk about Parvo before, you've heard me share this and say this. So this was, I just put the abstract up on the screen. Looking at the frequency of Parvo infection in puppies who were still going through their puppy series and attended puppy socialization classes. And they found that the vaccinated puppies were at no greater risk of Parvo infection than vaccinated puppies who didn't attend those classes. So I don't want to end on a note that suggests this isn't an important and serious condition in dogs and in cats, and that we don't want to be really mindful of doing all of the things that we can to protect infection and to protect the animals in our care. And I think we want to be really mindful that we are looking at and considering all of the tools in our toolbox and doing that in a way that best supports the animal's overall health and welfare. So with that, I will make you look at my lovely sleeping dog and see if there are any more questions for me.
Excellent. Yes. So we have a number of questions about vaccination, as I mentioned, and you did answer some of them. But so we have a question about vaccinating with modified live and puppies that may be getting adopted that have diarrhea. And so should people be testing puppies that are getting adopted who have just sort of diarrhea but are acting fine with the Parvo SNAP test when they are also vaccinated with modified live vaccines?
Yeah, so my short answer would be no. I think trying to pick up those puppies who are maybe shedding virus following vaccination, we don't really understand the clinical relevance of that. The other thing that I would say is where it does show up, where that was detected in all of those studies, was really looking through PCR because of the sensitivity. So there's a good chance that you wouldn't pick it up following vaccination on a SNAP test or one of the other manufacturer kits. But the other reason is because all diagnostic tests, how believable their results are influenced by 3 factors. What the sensitivity of the test is, so how good is it at not missing cases that it should pick up? What's the specificity of the test, which is how good is it at just getting that, right? So it doesn't have a lot of false positives. And then what's the prevalence? How common is what you're looking for actually out there? And when you start applying tests, even really, really good tests that have high sensitivity and high specificity, when you start applying those tests to populations that you expect will have a really low frequency of disease, outwardly healthy puppies that don't have compatible clinical signs, or a particularly risky history or known exposure, what you do to the reliability of those positive values is you push them way, way down. And so you may find the odd puppy who's positive that you caught really early, but in the process, you will misidentify a bunch of truly negative, but now incorrectly positively identified puppies. And that can have really significant implications for those dogs individually and for your organization, whether you're talking about quarantine or testing or treatment, or certainly if you're thinking about euthanasia.
Excellent, thank you. So there's been a number of people that are curious about vaccinating pregnant animals, cats and dogs. What do you recommend?
Yeah, so it sounded like a throwaway on the slide, and I did not at all intend it to be, but everything that we do, every medical decision that we make, and vaccinations are included in this, is a risk-benefit analysis. And so we're thinking about what are all of the risks of doing this, what are all of the benefits, and where that calculus falls is going to vary for different animals and for different situations. Generally speaking, if you are talking about animals who have a high risk of exposure, then the risk of not vaccinating is far worse than the risks of potentially vaccinating. And so you think about what would happen if you had a naive queen or dam who wasn't protected, who then got exposed to the actual infection, the detrimental effects that would be likely to have on her and her offspring are significant. Certainly if you are, and then there are other considerations, right? Where are the animals staying? Are they going to go to term and give birth, or are they going to be spayed prior to that point? That will influence your decision. What are your options for housing? Can they go into a really protected foster environment where we don't have to worry about that risk of not vaccinating them, and we can be uber careful for that very, I'll say mostly theoretical risk that you would have a negative impact. And so what the right answer is for that dog or for your organization is hard to give as a blanket, but those are the things that I would think through.
Yeah, and then the also the killed vaccines, another option, I think, as well. Excellent.
Yeah,
thank you.
The challenge with killed vaccines, right? And we didn't really talk about them, but the challenge with killed vaccines is they take longer and they don't do as good of a job at overriding maternal antibody interference. And so those two things coupled together in a shelter environment really make them not a very viable option in terms of getting that protection that we want to see on board.
Excellent, thank you. So then the next question about vaccines is whether modified live vaccines in particular can cause short-term clinical signs of parvo in dogs or cats.
I'm sorry, I was preoccupied with stopping sharing.
No worries. Yeah, so modified live vaccines, do we see vaccinal disease in dogs and cats as a consequence of the vaccine virus? Clinical signs.
So again, I'll give you the short answer and then the slightly longer answer. Probably not. We do see non-specific vaccine reactions that can include mild GI side effects, right, with any vaccine. I think part of the interest in those studies that were following those dogs and cats out with PCR was trying to look and see, so if they were positive, what are they shedding? Are they shedding vaccinal virus? Or are they shedding field strain? What does that really mean? Is there a concern for return to virulence or something like that? But there's really no evidence that if it happens with any sort of frequency. And it's been looked at in some, I would say, more vulnerable populations. So they looked at cushingoid dogs who were on trilostane, their response to vaccination with modified live, it was fine. They looked at retroviral infected cats. It was small numbers, but they looked at FELV positive and FIV positive cats, gave them modified live vaccinations, didn't see any complications.
Excellent. And then circling back to those pregnant cats and modified live vaccines, There was a question about whether the kittens in utero could be affected by the vaccine and potentially get cerebellar hypoplasia.
Yeah, so that's the reason, right? The concern with giving a modified live vaccine to a pregnant cat is that you could lead to some of those negative impacts on kittens that we can see with natural infection. So that what those are will depend on when it's given relative to gestation in terms of something like abortion, stillbirth, cerebellar hypoplasia, or otherwise. So it is a I don't want to say it's a completely theoretical risk, but it's not something that we have a lot of evidence that happens with any sort of regularity. And I think if you talk to a lot of shelter vets, especially a lot of shelter vets who have been in the field for a long time, we have vaccinated intentionally or not, just playing that risk-benefit game, a lot of pregnant cats. And it's not something, people definitely see it. It's not that it's impossible to happen, but it is not something that we see with an incredible regularity. So it really comes down to that individual decision that makes the most sense for that cat, her future kittens, your organization, and the environment and the risks that she's going to be facing.
Excellent. And then the last question is, and because we need to get out of this room because this room is where the next presentation is happening. At what point after recovery for Parvo or Panluke do you vaccinate?
Once they are well enough that again, remember you're vaccinating not to give them added protection or further protection for Parvo or Panluke. You're vaccinating them to give them the other things. Khaleesi, vaccines aren't great for the upper respiratory infections in cats, right? But Khaleesi and herpes in cats, and for dogs especially, distemper and adeno. And so once they're clinically recovered, that I'm like getting them back to their lives, they're back to normal, they're off of their treatments, then getting them vaccinated, getting them spayed and neutered, moving them on the way, I don't hold them back for any particular period of time.
Excellent. Thank you so much, Dr. Janesco. It was a very nice presentation, and we all learned a whole lot. Before we go, I want to direct everyone to the poll area on the right of your screen under the Stage tab. Please click on that icon to give us your feedback about this presentation. With your help, we can make our next conference next year even better. Thanks again, and looking forward to seeing everybody in the last session we have for today, which is modifying behavior in a shelter setting with Dr. Van Haften from the British Columbia SPCA. Thank you.
Awesome. Thank you, everybody.